Hi guys, give me a thumbs up if I'm visible to all of you. So give me a thumbs up if I'm visible to all of you. Guys, just give me a thumbs up again if I'm visible to all of you. Okay, fair. I'm waiting for a confirmation. Now I'm visible to all of you. Okay, cool. So let's start discussing the first question. The first question is about headache, and most of the university papers often give importance to headache as a question, major or a minor question. And when they ask question on headache, the structure of the question usually goes like this. Either they ask you to classify the headaches into primary, secondary, and different types of primary, or they ask you to discuss something called as red flag signs, and then the question leads into the topic proper. So the topic proper is either about migraine or tension type of headache, rarely cluster headache. Mostly it is about migraine or tension type of headache. Well, so let us begin by first classifying the headache. Though in this question there is no mention of classification, but your university paper might ask you to classify. So let us begin with the classification of headache. The headache is classified into two broad categories. The primary headache, where headache itself is a diagnosis, and a secondary headache, where headache is part of another disease where the real diagnosis is that disease. For example, meningitis. Meningitis is the diagnosis, but headache is one of the symptom. But tension type of headache, headache itself is a diagnosis. Migraine, headache itself is a diagnosis. So the headaches are classified into primary and secondary. And when we are talking about the primary, within primary we have cluster headache, tension type of headache, migraine, and a long list of other headaches. And then we have secondary headaches. Secondary headaches. Now, before we go into the primary headache, let me list some important causes for the secondary headache. So what are the important causes for secondary headache? Of course, for all of you, the first thing that comes to your mind is a tumor in the brain, right? Maybe what about a bleed in the brain? What about an abscess in the brain, right? All of them may present with headache. I will collectively call them as intracranial space occupying lesion. Intracranial space occupying lesion. Why are we calling them as intracranial space occupying lesion? Because inside the skull as we know is a very rigid structure, and it has space for normal anatomical structures, means normal sized brain, normal quantity of CSF, normal amount of blood flow through the brain, right? So it is having only space for the normal structures. If anything else is added inside this cranium, the cranium cannot expand, so there is no space available for the cranium to accommodate this foreign subjects or an extra item being added to this. So they are literally eating the space available for normal anatomical structures. So when something of that sort happens, it is eating up the space, literally compressing the surrounding structures, and because the cranium cannot expand, there will be rise in pressure inside the cranium. That's what we call as raised intracranial tension. So anything that eats up the space in the brain increases the intracranial tension, and it is not good for the health of the brain. So what are the examples? It could be an intracranial tumor, it could be bleed, or it could be abscess. It could be abscess. So these are secondary causes for headache. So what else I can count as a secondary cause for headache? Meningitis, meningoencephalitis. Meningitis is inflammation of the meninges. Meningoencephalitis refers to inflammation of meninges as well as the brain's parenchyma or tissue. Meningoencephalitis. They can also present with secondary headache. Then infections. Infections are also a known cause for secondary headache. Most of us, whenever we get infection, we have fever. When we have fever, we go through headache, right? In fact, we should also mention, and teachers would be pleased if you mention it, the most common cause for secondary headache is infections. And when I'm talking about infections, we are talking about infections generally, overall, not just the CNS infections. Even if you have malaria, you have typhoid, you have throat infection, right? You have intra-abdominal infection, you have an abscess somewhere, you do have headache along with that, right? So infections are the most common cause for secondary headaches. Now, when it comes to the primary headaches, remember primary headaches, we have tension type, and then we have migraine, and then we have a set of headaches called as trigeminal autonomic cephalgias, right? It's there in the name, trigeminal autonomic cephalgia. Cephalgia means head, algia means pain, cephalgia means headache. Here the headache is associated with autonomic symptoms. That's why collectively these are called as trigeminal autonomic cephalgia. Okay. Now migraine, as you know, is further classified into migraine with aura and migraine without aura. Migraine with aura and migraine without aura. And within this trigeminal autonomic cephalgias, we have three subtypes. So the first one, which is most important, most common trigeminal autonomic cephalgia, is cluster headache. Then we have paroxysmal hemicrania. Paroxysmal hemicrania. Hemi means one half, crania means brain or the head part. So hemicrania means you have half-sided headache. That too paroxysmal means intermittent, not constant. So constant unilateral headache is the meaning of this terminology. Paroxysmal hemicranial cephalgia or paroxysmal hemicrania. Then you have something called as short-lasting unilateral neuralgiform cephalgia with conjunctival tearing, or short-lasting unilateral neuralgiform headache with autonomic symptoms. So this is a basic classification. This structure is required to please the examiners. If examiners are asking you about classify headaches, this is what I want you to draw. Mention primary headaches on one side, secondary headaches on the other side. Secondary headache, important things that you should mention is, of course, you will be able to remember meningitis, you will be able to remember infections, you will be able to remember intracranial space occupying lesions. Primary, of course, you will be able to remember tension type of headache, you will be able to remember migraine, and you are familiar with cluster headache. Only thing I want you to know now is that cluster headache comes under a broad category called as trigeminal autonomic cephalgias. Once this classification is done, the next question is, in this question they have asked you to discuss red flag signs. Okay, so now let me think about myself as a clinician. So when I finished my postgraduate training and then started practice, I did not do senior residentship and all, I directly jumped into practice. I joined a clinic and started practicing. And every day I used to have some fears about some patients. Like someone presented to me with chest pain. Now I have done a preliminary evaluation and it doesn't look like a cardiac chest pain. I will send him home saying that it doesn't appear to be cardiac. It's most likely dyspepsia. I'm giving you some PPIs. Let us see. If you see chest pain worsening, come back. This is my counseling. But after sending the patient, I will always be worrying. What if it was an MI? What if on the way the fellow collapses? Then the mob will come and thrash me. So I always had that fear, right? Similarly, whenever I got a patient of headache and I diagnosed it as migraine and sent him home, I always used to bother. What if he had a tumor in the brain and it was discovered 2 months later by some other doctor? What about my reputation then? And what about patient's health then? I always had that worry, right? But then as I started practicing more, I realized that every symptom can be graded in terms of how risky that symptom is. Like, how is it pointing towards? Is it pointing towards a more sinister disease or more subtle, not so clinically dangerous disease? And the pointers which suggest that the underlying cause may be more dangerous, such pointers are called as red flag signs. Now you know, right? Like the red flag is a very famous terminology now, and you know red flag means what, right? So if you have a patient with headache and if along with headache these additional signs or symptoms are there, it is pointing towards more dangerous causes for headache, mainly pointing towards secondary headaches, as I can call it as, right? So what is the note I want you to write about red flag signs? So red flag signs are the signs with respect to headache. For every other disease, you may have red flag signs. So with respect to headache, red flag signs refer to signs and symptoms suggestive of secondary headaches. If you want, you can write with more negative clinical outcomes, secondary headaches. So let us make the list of those red flag signs. The first red flag sign that I want you to remember is age more than 50, or if you want, you can write 60 as well. Right? Age more than 50 to 55 years. This is one red flag sign. Second, presence of neck stiffness. Presence of fever is a red flag sign along with headache. Then the fourth one is presence of projectile vomiting. Fifth one, presence of neurological deficits. One of the body part is not working, right hand is not able to raise, right side of the body is not able to move, one side eyeball is not able to move. We will call them as neuro deficits. Presence of neuro deficits is a red flag sign. Okay, now let us also write explanations why these are red flag signs. Why age more than 55 years is a red flag sign? Can anybody tell me? Why should I consider it as a red flag sign? What are red flag signs? These are the signs which are pointing towards presence of a secondary headache. So let us say I got a patient who is complaining of headache. If any of these are present, it's not an exhaustive list, the important list for your prof exam. If any of these are present, I would start thinking about the possibility of secondary headaches. If red flag signs are not there, then possibility of secondary headache is less likely. Then I can think of diagnosis of tension type or migraine or cluster headache, right? So why age more than 55 years is a red flag sign? Well, the reason why it is red flag sign is most of the primary headaches that we have listed here in classification, be it tension type, migraine, cluster headache, paroxysmal hemicrania, all of them, the usual age of onset is second or third decade. You can say young people. So if someone presents with headache for the first time in his 60s or 70s, it is unlikely to be migraine, it is unlikely to be tension type, it is unlikely to be cluster. It's more likely to be something major. Like there may be a tumor, there may be a bleed, there may be an infection. So that's why it is a red flag sign. Particularly, I also want you to remember, I will give you the clue and let me see how many of you can get it right. You might have studied about it in pathology as well, and maybe opthal as well. So elderly patients presenting with headache, they feel they can palpate a cord-like structure in their temple region, and they have very high ESR, sometimes more than 100. And you study about this disease in rheumatology under the topic of vasculitis. So what am I talking about? What am I talking about? Elderly feels cord-like structure in the temporal region when he palpates, high ESR and vision at threat. He may lose vision if not treated. So what are we talking about? So we are talking about a condition called as temporal arteritis or giant cell arteritis. It is suggestive of giant cell or a temporal arteritis. So elderly male presenting with the headache for the first time, you should keep giant cell arteritis or temporal arteritis as one of the differential diagnoses. Only after clinically ruling that out, you can come to the diagnosis of the primary headaches, right? Neck stiffness is suggestive of meningitis. So of course it is a red flag sign. Fever is suggestive of infection, be it meningitis or non-CNS infections. And then projectile vomiting. Why is that a red flag sign? Projectile vomiting is where the vomiting is without nausea and the vomitus is projected far away from the patient. It is usually suggestive of raised intracranial tension, and raised intracranial tension may be suggestive of intracranial space occupying lesions. Means if the intracranial tension is high, probably it is because something is taking up the space inside the cranium. It could be tumor, bleed, abscess, any of those. So anyone who comes to me with headache and says, sir, I have vomiting profuse and no nausea, and the vomitus comes with no warning, it is projected far away from me, I will take that as a red flag sign. But if the patient says, sir, I have headache and I have severe nausea and then vomiting, it's not projectile vomiting, I literally go to sink, I try to induce to relieve myself of nausea. This story is very commonly encountered in patients with migraine. Migraine may be often accompanied by nausea and vomiting, right? Neurodeficits, if some part of the body, either motor system, sensory system is not working, it means there is something seriously problem symptomatic in the brain. There may be a bleed, there may be a tumor, or there may be an infarction, right? There may be an abscess, right? It is always suggestive of an organic neurological dysfunction. So it can't be a case of migraine or tension type of headache. Per se, with respect to the headache, weight loss alone won't be considered as a red flag sign, but weight loss which is unintentional and which is significant, means 10% or higher body weight being lost in 6 months of time, is always a red flag sign. It calls for more detailed investigation for underlying cause. Most cases, there will be either a cancer or chronic infections like tuberculosis or HIV or hematological malignancies. So now we know how do we deal with headache, right? Headache is classified into primary and secondary. Primary, we have to remember mainly 3: tension type, migraine, and a group called TAX. Within TAX, you have to remember at least cluster headache. If they ask you to elaborate on red flag signs, what are red flag signs? These are signs and symptoms. If present in a patient along with headache, they are pointing towards secondary headache rather than primary. Primary headaches will have no red flag signs. Tension type, usually ages young people, 20s, 30s. They don't have neck stiffness, they won't have fever, they won't have projectile vomiting, they won't have neurodeficits, right? Okay, so we come to the diagnosis of headaches, after primary headaches, after ruling out the secondary by ruling out the red flag signs. So you can make a note: primary headaches are diagnosed clinically after ruling out secondary headaches. Secondary headaches are often associated with red flag signs. They're often associated with red flag signs. Okay. Now this is the basic part of headache is completed. Now let us write about meningitis. Let us write about migraine that they're asking in this question, right? If they are asking about the tension type or cluster, we will modify the same answer. So we'll follow the same template for writing about migraine, tension type, as well as cluster headache. So let me start with the migraine first. So migraine is a primary headache. Migraine is a primary headache. The key points I want you to write when you're writing about headache is, first thing is whether the headache is unilateral or bilateral, because that helps you to differentiate. Differential diagnosis के लिए बहुत important है. Second, the duration of headache attacks. When a tension type of headache attack happens, how long it lasts. When a migraine attack happens, how long it lasts. And whether there are any additional associated symptoms or clues in the patient's history, right? What are the 3 points? Laterality, unilateral or bilateral, duration of attacks, and associated symptoms. So when we are talking about migraine, migraine is unilateral primary headache, unilateral episodic headache. Tension type is bilateral. All the TACs, cluster headache, Santhosh, they are all unilateral. So only tension type of headache is bilateral among the primary. That way it is very easy to remember. So unilateral episodic headache, episodes last for, so whenever an attack of migraine happens, they last for 4 to 72 hours. 4 to 72 hours. Very, very important. Your teachers are specifically looking for these pointers. You should mention unilateral, you should mention 4 to 72 hours. And headaches are often associated with. So what are the associated symptoms that we get in migraine patients? So the first thing I want you to mention is nausea and vomiting. Nausea and vomiting. The second one I want you to mention is they often have photophobia, that is intolerance to bright light, and phonophobia, that is intolerance to loud sounds or noises. Photophobia and phonophobia. Then third, how many of you have migraine here? A lot of patients with migraine, they often feel that their migraine headache worsens whenever they either lean forward, move their head, or try to do any physical activities. So, and because of that, they try to avoid doing physical activities, because whenever they try to do physical activities, the headache worsens, right? So headache here worsens on physical activities. The fourth one, maybe, right? Again, specifically, I want you to write this: maybe migraine may be associated with aura. Why are we saying maybe? We are saying maybe because majority of the patients of migraine do not have aura. So patients with migraine without aura are more common than patients with migraine with aura. Okay. Now we will write a short note on what is this aura. What is this aura? Right? Can anybody tell me what is this aura? Aura. Not that aura farming. What is aura? So aura refers to abnormal motor or sensory system function related symptoms that patients experience before the onset of headache. Means first aura comes and then headache comes. So these are abnormal motor or sensory symptoms experienced by patients before the onset of headache. Now I also want you to remember that many times the questions may also ask you to discuss about aura. So when there is a question on migraine for 20 marks and they have specifically mentioned discuss about aura, that means 5 marks or 4 marks are reserved for your discussion on the aura. So you have to clearly define what is it. These are abnormal motor or sensory symptoms experienced by patients before the onset of headache. And the second point I want you to mention is these are reversible. These are perfectly reversible symptoms, not persistent, permanent symptoms. Because one of the sensory symptoms they can experience is loss of vision. It's not going to be permanent. By the time headache starts, most of them would have recovered the vision. So before the headache, they might lose vision. With the onset of headache, the vision is recovered. So aura usually lasts for, because it is reversible, it should be lasting for a short period of time. So aura usually lasts for 5 to 60 minutes. 5 to 60 minutes. Headache usually lasts for 4 hours to 72 hours. So before that, 5 to 60 minutes, some patients may experience abnormal sensory or motor symptoms. So what are the common auras that patients experience? So few points here. Sensory auras are more common than motor. Sensory is more common than motor. That means the symptoms that patients are going to go through are mostly related to sensory system than motor system, right? So among the sensory system, it is the vision which is most commonly affected. Visual disturbances. Vision is also a sensory system. Remember, sensory system is classified into special and non-special. So vision, smell, olfaction, taste or gustatory sensation, audition or hearing, these are considered as special sensations. And then touch, pain, temperature, vibration, these are considered as non-special sensations, right? Okay, just out of curiosity I'm asking, can anybody tell me why these vision, touch and vision, taste, olfaction, hearing or audition, these are considered as special sensations? How are they different from the general non-special sensations? The difference is these sensations have dedicated sensory organs. Means vision, I can't see through my whole body, I can only see through my eyes. I can't smell through my whole body, I can only smell through my nose. So they have dedicated sensory organs, and the signal from these special sensations reach the brain through dedicated cranial nerves, right? You have olfactory nerve, right? You have optic nerve. So you have dedicated cranial nerves to take the sensation to brain. But for the other general sensations, cranial nerves take the sensations to the brain, spinal nerves also take the sensation to brain. So I can feel the touch from head to anywhere. They don't have a dedicated sensory organ, right? So vision is also a sensory system, it's a special sense. So the most common aura is going to be visual. Now what abnormal visual perception these patients are going to face? They may face seeing some zigzag lines in their visual field, or they may see floaters in their visual field. You know, those worm-like structures, translucent, that they appear to float in our visual field sometimes. So these patients also go through that. In fact, a lot more floaters or a lot more worm-like structures floating in their visual field before the headache starts. So seeing floaters, zigzag lines, or seeing flashing lights, these are more common aura, right? And when this common aura is present, the visual aura is also called as, visual aura is also known as typical aura, because that's what is most commonly encountered in patients with migraine plus aura. It's called as typical aura. But then the other auras this patient can experience is vision loss. They can absolutely lose the vision on whichever side they have headache. I have right-sided migraine, right vision I might lose. So vision loss. Then they can even experience hemiplegia. Hemiplegia, just before the onset of headache, one side of the body they can't move. For 5 to 60 minutes, they are absolutely immobile. Hemiplegia. Then brainstem dysfunction. Brainstem dysfunction before the onset of headache. But as the headache starts, the dysfunction resolves. So when vision loss happens, it is called as retinal migraine. Retinal migraine. If vision loss is part of the aura, we call it as retinal migraine. If hemiplegia occurs, it is called as hemiplegic migraine. Hemiplegic migraine. And these auras are not very common. They are rare. So if they are present, we will call it as atypical aura. It will be called as atypical aura. Okay, and I also want to tell you that if you can make a visual representation of information or data, you don't have to write long sentences. Your professors are not going to judge you for not writing long sentences. They are only trying to judge whether you know the stuff or not. So only introductory statements that you make, keep it full sentences. After that, try to represent more information or data through visual representation, like how you make notes for yourself. But of course, like not an unacceptable short form and all, you should not use them. But otherwise, you can use flowcharts, you can use tables. Try to make more information visible clearly rather than writing lengthy sentences. The teachers are not going to spend a lot of time reading your lengthy sentences, right? Okay. So this is about aura. What is aura? Abnormal motor or sensory perceptions that patients experience before the onset of symptoms. These are reversible symptoms. They last for 5 to 60 minutes. Commonly, sensory is more commonly seen than motor. Motor is mostly in the form of hemiplegia. Within the sensory, most commonly they experience the visual disturbances like seeing zigzag lines, floaters, or flashing of lights. Other than that, they may lose vision, that is retinal migraine. They may have hemiplegia, that is hemiplegic migraine, or sometimes they can develop cranial nerve loss of function, that is brainstem dysfunction. So if these auras are present, these auras are called as atypical aura. Okay. And then now you can make a note that migraine with aura is also called as yes, even the tingling sensation is an abnormal sensory perception. I have not listed the whole list of auras that patients experience. These are the common ones. But yes, if you are experiencing tingling sensations before the onset of migraine headache, it is still considered as an aura. Migraine with aura is called as classical migraine, and migraine without aura is called as non-classical migraine. Migraine without aura is called as non-classical migraine. So as I've already told you, your teachers are looking for 3 levels of information in your written question. What are those about headache? First one, they want you to clearly mention whether this particular headache is unilateral or bilateral. Migraine is unilateral. Second, they want you to mention the duration of attacks. Migraine lasts for 4 hours to 72 hours. That also means anything less than 4 hours untreated, anything more than 72 hours untreated is unlikely to be migraine. Third, associated symptoms. So we have already listed nausea, vomiting, photophobia, phonophobia, physical activities worsening the headache, and aura if it is present. That is classical migraine. Without it, it's still migraine. We will call it as non-classical. So if these symptoms are present, then we would consider it as a case of, possibly a case of migraine. Now the question is, how will I take this to diagnosis? Should I go for CT scan, MRI, or any of these investigations? Jilani Khan, this is a NEET PG division. So the best person to tell you which batch is right for you for the NEET UG is a faculty from the NEET UG. So you can definitely ping one of them and they will be more than happy to help you. Okay. So now remember the diagnosis of all the primary headaches, be it migraine, tension type, cluster headaches, and Suna, paroxysmal hemicrania, all of them is based on clinical judgments, not on investigation. Unnecessarily, you don't have to do CT scan, MRI for all the patients of headache. In that case, a neurologist should end up ordering CT and MRI for all patients who are walking into his OPD, not called for. But then what if I miss a tumor? Well, that's why we discussed about the red flag signs. So if you get a patient of headache with red flag signs, it is more pointing towards the secondary headache. Investigate them, do a detailed evaluation. But if there are no red flag signs, then it is most likely fitting into the primary headache. So you can go ahead and diagnose it as primary headache. So diagnosis, you can write it is clinical. You have to rule out secondary headaches by ruling out the presence of red flag signs. So if I get an elderly, like 70-year-old man presenting with unilateral headache, I won't think of migraine because he is elderly. Age is a red flag sign. So I would be thinking of some secondary cause. So I will investigate. I might, like from the history, I will try to get clues. If nothing comes, at least I will do an imaging of the brain. Right? I will do the ESR because giant cell arteritis is common in that age group. So I will investigate. But if I get a 20-year-old, 30-year-old presenting with unilateral headache, episodic headache, giving me the history of few months, having gone through multiple attacks, and age is not a red flag sign, there is no projectile vomiting, there are no neurodeficits, nothing pointing towards a secondary cause, then I will come to the diagnosis of the primary headache, right? So you have to rule out the secondary headaches by ruling out the red flag signs. And you can write, if you want, if red flag signs are present, a detailed investigation is recommended. If no red flag signs present, then the diagnosis is clinical. Don't investigate anything. Diagnose it as migraine or tension type headache, what it is fitting according to the history. Okay. And then the other thing I want you to mention here is that number of attacks required for diagnosis. Means if someone presents with headache for the first time, I don't label it as migraine. I don't label it as tension type of headache. It could be simply because of inadequate rest, right? Alcohol, hangover, caffeine withdrawal, stress, inadequate sleep. Quite common. Like if a medical student comes and says, "Sir, I'm having headache," should I label it as straight away as migraine? No. Maybe yesterday he did a late night study or a late night party. So either it's because of lack of sleep or it's because of alcoholic hangover, he may be having the headache. So I don't have to label it as migraine with just one episode. So we need to have a minimum number of episodes of headache meeting all the criteria as we discussed. It should be unilateral, lasting for 4 to 72 hours with nausea, vomiting, photophobia, all these should be present. Then only we can diagnose it as migraine. If it is classical migraine, the number of attacks required for diagnosis is more than or equal to 2. That means first time we don't label it as migraine. Second time the same story repeats, attack lasts for 4 to 72 hours, it is unilateral, associated with maybe photophobia, phonophobia, nausea, vomiting, and he has aura, that is classical. Second episode, enough. But if it is non-classical, that is without aura, 2 episodes are not enough. I need more. Why I need more? Because the other headaches will still remain a differential diagnosis if aura is not there. If aura is there, I don't get aura in tension type of headache. I don't get aura in cluster headache. I don't get aura if I have a CNS bleed. So in other cases, the aura is less likely. That's why the second time the patient comes back, we are labeling it as migraine. But if it is non-classical, where aura is not there, I need at least 5 attacks of headache before I label it as migraine. Okay, so diagnosis में क्या क्या लिखना है? You have to mention that it is clinical. You are ruling out the secondary headaches on the clinical grounds by ruling out the presence of red flag signs. And then you are labeling it as migraine. If it is with aura, then 2 attacks have already occurred. And if it is without aura, 5 attacks have already occurred. Till that time, you can't label it as migraine. Now that we have learned about diagnosis, we will also write about management. Now, all these primary headaches that we are talking about, these are episodic headache. That means the headaches keep recurring again and again. It's not like, okay, I got migraine now and I will never ever get migraine in my life. No, if I have migraine, it'll come today, after a few days it might come again. So it keeps recurring. It's a episodic headache. Tension type also same, cluster also same. And because of that, when we talk about management, we will have two levels of management. First, I'm going through a migraine attack now, you have to relieve it. That is acute treatment. But then you as a doctor know that it will come back again. So you have to prevent. Next time when it is about to come, you have to prevent. So we'll have two levels of management: acute treatment to relieve an ongoing headache, and preventive treatment to make sure or to ensure that the headache doesn't hit the patient again in the near future. So in the management, the acute treatment, that is to relieve the headache, the currently accepted drug of choice are triptans. Triptans are vasoconstrictors. Triptans are vasoconstrictors. And for the preventive treatment, to ensure that the headache doesn't bother the patient again, the currently accepted drug of choice is propranolol, which is a beta blocker, as you know, non-selective beta blocker. Now, some of your teachers, especially during Viva ask, if you are presenting a neuro case, the discussion may be dragged into headache, and very often they ask, what will you prescribe if patient has got some contraindication for beta blockers, like he is asthmatic, or he has already some cardiac issue and he is in bradycardia, like he has some AV blocks. You can't give propranolol, right? So what are the alternatives in those cases, in asthmatic or any other contraindication for beta blockers? Alternatives to propranolol, what I can prescribe, right? I will mention 3 or 4. In your pharmac book you might get a long list, at least 3 or 4, so that the examiner feels that you know the alternatives as well. So the key ones that I want you to mention, the first one is, I would rather prefer you to mention valproate, sodium valproate or valproic acid derivatives, right? Valproate, venlafaxine, topiramate, and candesartan. Candesartan is a ARB, right? It is an antihypertensive, but it also has migraine preventive properties. So these are main pharmacotherapeutic alternatives. You can also do Botox to the scalp. The Botox technical term is onabotulinum toxin A. So today, because the main aim is to help you deal with your upcoming prof exam, I'm not discussing the mechanisms or reasons why these drugs find a place in the management of migraine. But later when we discuss migraine in detail, when you clear the prof and start preparing for the NEET PG, I will address every drug why it finds a place in this list. Onabotulinum toxin A. The other thing we can do is there are devices which stimulate the vagus nerve. So these are all alternatives to propranolol or beta blockers for the preventive treatment of migraine. Okay, so that's about the migraine. Now the same question, your university, instead of asking about migraine, they may ask about tension type headache, or they may ask about cluster headache, right? So if you know the key differences, you can apply the same protocol for writing the answer. Okay, Zubi, I will address the pathogenesis as well. Okay, so what is the pathogenesis, if they're asking? So pathogenesis of migraine has evolved a lot. So only key points I will mention that you can use as headings for writing if they're asking about the pathogenesis of migraine. So one I want you to mention is vascular theory. B, neurotransmitter theory. So what vascular theory said is the headache is because of vasodilatation. Makes sense. Why does it make sense? Because if I cause vasodilatation in some part of the brain, blood vessel is dilated, more blood is flowing to that part of the brain. But do I have the space to accommodate this extra surge of blood into the brain? No. My skull has set a limit. It says I will accommodate the normal sized brain, normal amount of CSF, normal amount of blood flow. Right? I don't have space for extra amount of blood flow. I don't have space for extra CSF. I don't have space for any extra tissue. So if I increase the blood flow to some part of the brain, localized intracranial tension increases and that triggers the headache. This is the basis of vascular theory. So what vascular theory said is vasodilatation is the reason for the headache. And to support that theory, the response to triptans is very important, because if I give triptans, the headache gets relieved, which is a vasoconstrictor. So vasodilatation is causing the headache. Give a vasoconstrictor, constrict the blood vessel, blood flow to the affected part of the brain comes down, the headache comes down. Makes sense. But it is not fully accepted today as a theory. It may have a contributory role. So what vascular theory said is vasodilatation is responsible for the development of headache. But then this theory does not explain why vasodilatation happened. Okay, but the theory also says that the aura that we saw, right? Patient was losing vision, or patient was losing one side body movement, hemiplegia. The aura phase can be explained by vasoconstriction. Like if I constrict the blood flow to the occipital cortex, which is concerned with vision, will I be able to maintain vision? No, I will lose. If I constrict or reduce the blood flow to motor area, I will lose the motor function. I will become hemiplegic. If right frontal lobe loses the blood flow or it comes down, I will develop left-sided hemiplegia as part of aura. So it all starts with vasoconstriction. We get the aura, and to counter that, body causes vasodilatation, and that vasodilatation leads to headache. So according to this vascular theory, vasodilatation is responsible for headache and vasoconstriction is responsible for aura. Vasoconstriction is responsible for aura. But still theory fails to explain why vasoconstriction happened. So why we got vasodilatation more than required in response to vasoconstriction. This is a basic understanding, but this theory has helped us to develop the drugs. Triptans are vasoconstrictors. We use them when headache is going on, because headache is going on means vasodilatation has already occurred. But if you want to prevent, according to the theory, first vasoconstriction happens and then vasodilatation. So if you want to prevent, you have to prevent vasoconstriction. If there is no vasoconstriction, there is no vasodilatation happening. So you won't have headache. That's why we use beta blockers, which act as vasodilators, so that there is no vasoconstriction. No vasoconstriction means unnecessary vasodilatation will not happen in the future. So you will not have a migraine attack from coming. So this is one thing you can mention about the theory. Second thing, the neurotransmitter theory. Neurotransmitter theory primarily talks about imbalances in the neurotransmitters resulting in the headache. The key points I want you to mention here is there is increased production of calcitonin gene related peptide. Calcitonin gene related peptide, which is actually vasodilator. So when vasoconstriction had happened, to counter that, CGRP might increase, and that may be causing unnecessary vasodilatation, that may be causing headache. Okay, so that is second. Then there is also a third contributor to the pathogenesis of migraine, which is called as cortical spreading depression. Cortical spreading depression. Now what is this? See, when you look at the drugs that I mentioned, some of the drugs are anticonvulsants, right? Valproate, where do you use it? For seizures. Topiramate, anticonvulsant. So why anticonvulsants are finding a place in preventive treatment of migraine? Is it seizure? No, right? But there are some similarities. What is a seizure? Seizure refers to abnormal electrical discharges in the brain. And what is an abnormal electrical discharge? Depolarization, right? So an abnormal depolarization can also be a reason for triggering the migraine. So similar to seizures, a wave of depolarization spreading through the cerebral cortex. And as part of that wave of depolarization, you may produce various vasoconstrictors. The theory goes like this. You have a wave of abnormal depolarization spreading through the neuron, similar to seizures, you can call it as. And because of that, there is production of vasoconstrictory substances. So they cause the vasoconstriction. So cortical spreading depression leads to vasoconstriction. To counter that, CGRP and other vasodilators come into picture. They cause vasodilatation and you end up with headache, right? So what should I write about cortical spreading depression? A wave of abnormal depolarization. Spreading across cerebral cortex. And another component in the pathogenesis is hyperactivity or hyperstimulation of trigeminal nerve. So these are all contributory factors in the pathogenesis of migraine. So it's a bit complex. As long as you're able to list vascular theory and neurotransmitter theory, your teachers will be more than pleased, because pathogenesis will not carry a weightage of more than 3 marks. So this much is enough. Okay. So now that we have learned about migraine, let us follow the same template for the tension type of headache as well. So first point is migraine was unilateral episodic headache. Tension type is bilateral episodic headache. First point, that is different. Second thing, the episodes of tension type may last for days. Okay. Then third, what are the associated symptoms of tension type of headache? The tension type of headache generally does not have photophobia, phonophobia. So there are no major associated symptoms. So you don't generally have photophobia, phonophobia, nausea, or vomiting. But you can definitely mention certain clues in the patient's history. So what are the clues towards the presence of tension type of headache in the patient? Number one, presence of stressful life events. Very often the tension type of headache start when patients are going through a stressful phase in their life. So there are life stressors present, stressful life events. Second, these patients describe pain as, this is very important, teachers are often looking for this, band-like sensation, or they describe it as voice-like grip. Because see, migraine headache is very severe. It's not a mild pain, but the tension type of headache is never severe. Tension type of headache is mild or moderate. It's not going to be severe. So migraine patients often come to us and say, sir, my head is about to burst. It's a pulsating, throbbing headache. But the tension type of headache is a dull aching, kind of heaviness. So Indian patients often describe it as, sir bhari ho raha hai, head feels heavy. That's the usual description of our patients. That's what in the books they call it as vice-like grip. It feels like a tight grip or a band-like sensation. You know, in Ganesha festival and Deepavali and all, people wear a band on their forehead, right, running to go behind the head, right, around the nape of the neck is where they tie it. So that's exactly the distribution of pain. So that's why it is described as band-like sensation. So now diagnosis, nothing specific. Same thing you will write for the diagnosis. What you will write? Diagnosis is clinical. You have to rule out red flag signs. That's it. So in terms of management, what should I write? Same, what is used for acute treatment and what is used for preventive treatment. So for acute treatment, because it is not very severe, it's not like migraine. In migraine, we had to use a vasoconstrictor like triptan. We don't need any specialized drugs for tension type of headache because it is mild headache or moderate headache. We will use NSAIDs. And for prevention, generally the tension type of headache lasts as long as the stressful events persist in the patient's life and may recur again once the patient goes through stressful situations again. So that's why we might have to extend the preventive treatment for at least 3 months. And the drug of choice for the preventive treatment is going to be amitriptyline. Amitriptyline, which facilitates coping up with the stressful events that are bothering the patient currently and reduces the frequency of migraine attacks. So amitriptyline is a drug of choice for preventive treatment. NSAIDs is the drug of choice for acute treatment. For migraine, triptans were the drug of choice for acute treatment, and propranolol was the drug of choice for preventive treatment. Right. So on the similar lines, we will also write about cluster headache, because the same question may be asked about cluster headache. So cluster headache is we discussed about cluster headache under the title of trigeminal autonomic cephalgias. Trigeminal autonomic cephalgias. Right. Now I want your attention on the name. It's called trigeminal. Why? Because the distribution of the headache is in the same region as the distribution of the trigeminal. You know, ophthalmic, maxillary, mandibular 3. Pain is here mainly. Right. Tension type of headache and the migraine, they were more on the forehead, temporal region, right? And then occipital region. This is more on the face, less on the cranium, more on the face. That is where the distribution of the trigeminal is, right? That's why it is called as trigeminal. Why is it called as autonomic? Because they have, in addition to headache, as an associated symptom, just like how we had aura for migraine, these have parasympathetic overactivity. Localized means not whole body parasympathetic overactivity. Whichever region, whichever side they have headache, they have parasympathetic overactivity. That's why we are using the distribution is trigeminal distribution, same way, same location there is a pain, and this patient's headache is associated with overactivity of the parasympathetic nervous system in the affected region. So then tell me, what are the symptoms I can expect? So cluster headache is unilateral episodic headaches unilateral episodic headaches. I'll leave just 2 lines there for a more descriptive text. These are unilateral episodic headaches associated with localized parasympathetic overactivity. Now, what symptoms I can expect? So remember, parasympathetic nervous system plays a very important role in regulating the glands, in regulating the blood vessels. You know, acetylcholine is the main neurotransmitter of the parasympathetic nervous system, and majority of the glands secrete when parasympathetic gets activated. So all the glands that come in this region, their activity will be increased. Then parasympathetic nervous system causes vasodilatation. Sympathetic nervous system causes vasoconstriction. So if parasympathetic overactivity is there, there will be vasodilatation in the affected part, right? So what symptoms we can expect? Vasodilatation in the blood vessels of the eye. What it will lead to? In the conjunctiva, if the blood vessels dilate, how the eye will appear? Red, right? So conjunctival redness. Okay, then vasodilatation of whole of this face, right? How this face will look? It will look red, right? Because more blood is flowing in that region because of vasodilatation. When you get that redness of the face, whole face, when someone passes a nice comment to you, right? You call it as blushing. You know why is that happening? It's same because of parasympathetic. See, when someone criticizes you, blames you, starts quarreling, right, with you, your sympathetic nervous system gets activated. But when someone starts praising you, right, giving you cute comments or compliments, your parasympathetic gets activated. So you will have vasodilatation. That vasodilatation gives that glow on the face, right? That redness you see, what you call as blushing. But here it is pathological, so I won't call it as blushing. Rather, I will call it as flushing of the face. It's unilateral. So if I have right-sided headache, I will have right-sided flushing or redness of the face. Okay, then I have lacrimal glands. Parasympathetic overactivity means lacrimal gland activity will increase. I will have tearing or lacrimation. Okay, then I will have nose blocks. Why will I have nose blocks? It's not only because increased secretion by the nasal epithelial glands. There's a more important reason. Parasympathetic is causing vasodilatation. So if I have vasodilatation of blood vessels in the nasal mucosa, they become swollen because more blood is coming to them. So if the nasal mucosa gets swollen, the passage becomes narrow. So that's why whenever we have cold, many times you have dry cold, right? You don't have running nose, you just have dryness of the nose, but you feel nose is blocked. So it's not blocked by secretions, it's blocked because of vasodilatation. And you put one Otrivin or Nazivion drop, xylometazoline, oxymetazoline drops, immediately you feel the relief because they are vasoconstrictors, right? So here also, without the infection, you are developing vasodilatation because of parasympathetic activity. So that will cause nasal stuffiness. Okay, not just that, the parasympathetic overactivity might also affect your pupils. Pupils are usually constricted by the parasympathetic nervous system. So you will have constricted pupil, you call it as miosis. So all these symptoms may be associated with a patient of cluster headache. Okay. Then the third thing that you have to write. What are the three things always you have to write about headache? Laterality, unilateral or bilateral. Second is duration, and the third one is associated symptoms, right? So with respect to duration, the cluster headaches usually last for 15 to 180 minutes. Means anything that is lasting for 4 hours is not going to be cluster headache, because cluster headache resolves by itself by maximum 3 hours, not beyond that. Anything lasting for 4 hours or plus, we're thinking of migraine. 4 to 72 hours is migraine. Cluster headache lasts for less than 4 hours. Okay. Now I had asked you to leave a little space here, right? You know why? Because this is one very peculiar headache. This headache, the episodic headaches, they follow circadian and circannual pattern. Okay, now what do I mean by this circadian and circannual pattern? Very peculiar. It's something that you don't usually encounter in tension type or migraine or any of the other primary headaches, but typically encountered in cluster. In fact, the term cluster headache comes from this pattern. Okay, so just to make you understand, you don't have to sketch this graph, but it is for your conceptual understanding. As long as you mention follow circadian and circannual pattern, it is more than enough. But I want you to understand what does that mean. So let us say that I have got 2 patients. Both of them are having migraine. Okay, sorry, one of them is having migraine, one of them is having cluster headache. Let us say both of them experienced 50 attacks of headache in last 1 year. Let us say patient A is a case of migraine and patient B is a case of cluster headache. So patient A experienced 50 attacks of migraine in last 1 year. Patient B experienced 50 attacks of cluster headache in last 1 year. And I plot their headache episodes, like which dates headache happened, on a calendar. Okay. So let us say on the x-axis, I'm plotting the months. Like let us say this is first quarter, right? Jan to March. Then March to April, May, June. June to July, August, September, and then eventually December, right? This is the calendar I have plotted. A was a case of migraine. So one thing we notice in migraine is that the headache episodes are kind of uniformly distributed throughout the year. Not much of grouping happens. So if 50 attacks have happened, and if I plot them, 50 attacks appear like this. They're happening kind of throughout the year. But a 50 attacks of a patient that is a case of cluster headache, you may see them all happening in a very short period of time. Both of them had 50 only, right? But let us say this patient will have most of his 50 attacks between maybe Jan to September, or like June to September, or maybe only in June, July, or maybe July, August, or June to September, somewhere there. So because these attacks are all grouped together in a very short span of time across this whole year, it is called as cluster. There is a clustering behavior seen. That's why we call it as cluster headache. And when you say circannual pattern, means every year. So this year between June to September, he experienced headaches of cluster attack. Next year also it will come in the same period between June to September. Subsequent year also it will come in the same period. So if it is winter season, every winter season he will experience the headaches. If it is summer season, every summer season he will experience the headache. That's what is the meaning of circannual pattern. Every year it is the same period of time where patients start experiencing headache attacks. And then between June to September that he is experiencing headaches, those headaches generally come at the same time of the day. Like, okay, I know I had last year June and July attacks of headache. So this year also June and July I will have attacks of headache. And within that June and July, every day it comes at same time. Like, okay, yesterday I had one attack at 11 a.m. and another at 4 p.m. So today also I will have one attack at 11 a.m., another at 4 p.m. So it is like same time of the year, same time of the day. That is what circadian means, same time of the day. Every day it keeps, once the cluster starts, every day it keeps coming at the same time. So that is very peculiar of the cluster headache, and that's why we have named it as cluster. All the attacks are clustered in a very tiny space of time. Okay, so you understood why it is called as cluster headache. And within that, we also understand one special logic. When we are managing cluster headache, we have a little different approach. What is the difference? Tension type and migraine, we had acute treatment, preventive treatment. But when it comes to cluster headache, the preventive treatment is split into two: the short-term prevention and long-term prevention. Okay, so now this person is experiencing an acute attack of headache here. So I have to relieve that headache. So that is acute treatment. But tomorrow he is going to get again, I have to prevent it. Day after tomorrow he is going to get it again, I have to prevent it. That is short-term prevention. This season's problem is solved. Next year again it's going to come, this cluster is going to come. Before that I have to also institute a preventive treatment so that the cluster only don't appear. Sorry. So we'll call it as long-term prevention. So we'll have a short-term and a long-term prevention. Okay, I will leave this map on the notes just for you guys to be able to relate to it conceptually, but you're not expected to write it in your paper. Okay, so what do we learn about cluster headache? Unilateral headaches lasting for 15 to 180 minutes, that is 15 minutes to 3 hours, associated with unilateral parasympathetic overactivity related symptoms. That's why the term autonomic comes into its naming, and it follows a circadian and circannual pattern. It appears same time every year and same day of those attack periods. Now diagnosis, you will write the same thing, that is clinical, after ruling out the red flag signs. Okay, one extra point I want you to mention is that these clusters are so Tapa, because it appears as a cluster, once a cluster starts, to treat the current ongoing episode of headache, whatever drug we use, that is acute treatment. Now this cluster, today's problem is solved, but this whole season he is going to experience headache. So whatever medications I give so that this season he does not experience another episode of headache is short-term prevention. And then next year, same season, again the headache is going to come. So whatever medications I start before that season so that the headaches do not start bothering him, that will be called as long-term prevention. Okay, another extra point I want you to mention is that cluster headaches are usually precipitated by alcohol. So alcohol is a trigger for cluster headache. Migraine need not always be triggered by alcohol. In fact, many patients of migraine, the attack is triggered by the hangover or alcohol withdrawal rather than alcohol. But for cluster headache, drink now, tomorrow you start getting the headaches. So alcohol is a precipitating factor. This is also an important point for your MCQ exam. Okay, so this is about the cluster headache. Diagnosis, you will write the same thing. Diagnosis is clinical. You have to rule out the secondary headaches by looking at the red flag signs. So when it comes to writing a note on the management of cluster headache, as I've already told you, you will have an acute treatment, then short-term prevention and long-term prevention. So for acute treatment currently, because with time the advancements in the science keeps changing what is considered as acute treatment. So currently the drug of choice for acute treatment is subcutaneous sumatriptan. And if sumatriptan is contraindicated, like in patients, sumatriptan is a vasoconstrictor, triptan. So if patient already has some blood flow limitations like coronary artery disease or a stroke, we don't want to use triptans because already blood flow limitation is there to the heart or the brain, and I constrict the blood vessels, it will worsen the condition. So in such cases, oxygen can be considered as the alternative. So once upon a time, oxygen was considered as a drug of choice. Now that we have safer routes of administration of sumatriptan, subcutaneous sumatriptan is now considered as the drug of choice. For short-term prevention, the drug of choice is glucocorticoids. And for long-term prevention, the drug of choice is going to be verapamil, which is a calcium channel blocker, non-DHP calcium channel blocker. So that completes the discussion on the headache. So what I want you to remember, just 3 points. See, rest of the things you can kind of inflate it. You should know lateral, unilateral or bilateral. You should know the duration of attacks, and you should know the associated symptoms. Even if your university asks a story-based question, like they give the story, this patient presented with headache, unilateral, bilateral, photophobia is there or not there, right? Even if they give a story, as long as you know these 3 things, you will be able to understand whether this question or this patient's story is about migraine, tension type, or cluster, right? After that, in the management, you're talking about the drug of choice for acute and preventive treatment. That's it. Okay. So after the headache, let's go to the next important question from neurology. Next important question is about GB syndrome. The question may go like this: what is Guillain-Barre syndrome or GB syndrome? Discuss clinical presentation, diagnosis, and management, right? So can anybody tell me what is GB syndrome? There is nothing called normal headache. So headache always has a cause. So the cause is a long list of conditions that can cause headache. So among them, tension type is one, cluster is one, migraine is one, and a lot of secondary headaches. Secondary headaches can be drug withdrawal headache. Secondary headache can be medication overuse headache. Secondary headache can be hunger headache. Even when you feel hungry, you have seen that ad, no? Who is that? Sonakshi Sinha. She becomes wild when she's hungry, but after getting some chocolate, she settles down. Well, it happens. Means you can get headache when your blood glucose levels are dipping, or if you have hypoglycemia. You can have headaches when you have fever, you have infections. So all of them are causes for headache. There's nothing called normal headache. So most of the students, when you experience headache, it's a secondary headache. It's because you have not adequately rested, or you have a sleep deprived night. So you have always a cause. There's nothing called normal headache. Nobody goes through a normal headache. Okay. Secondary headaches are the ones where you have a cause, but then you don't have any other diagnosis. Headache is the only thing, and where headaches keep recurring again and again with a similar characteristics, then we will call it as primary. So among the primary, 3 things that you need to remember is tension type, migraine, and the cluster. So tension type is also a recurrent headache. Many times students have this confusion that I have got tension type headache. Like, so 6 months back, I had an episode of headache. I took paracetamol, it settled. So I'm very much sure that that was a secondary headache. It could be because of hunger, it could be fatigue, it could be because of sleep deprivation, it could be because you had alcohol, any of them. But it was a secondary headache. Tension type of headache keeps recurring. It's a episodic recurrent headache. Migraine keeps recurring. Cluster headache keeps recurring. So if it is not recurrent, it is not likely to be a simple primary headache. Okay. Now coming to GB syndrome. Yes, GB syndrome is an inflammatory autoimmune disease, but affecting what? It's a good definition. Definition or introduction to GB syndrome should go like this. Yes, it is acute inflammatory demyelinating. Okay, acceptable, still not very perfect. So let me make this a perfect, like a good acceptable definition for GB syndrome. So GB syndrome is a infection triggered. Means yes, it is an autoimmune process which is responsible for damage to peripheral nerves. GB syndrome is a peripheral nerve disorder. It's not a disorder of the central nervous system. GB syndrome is not affecting your brain. It is not affecting your spinal cord. It is affecting your peripheral nervous system, that is cranial nerves and spinal nerves. So it's an infection, and the reason why autoimmune process is targeting your neurons is infection. So it is an infection triggered autoimmune inflammatory and when I'm talking about a peripheral nervous system disorder, remember you have a central nervous system that includes brain and spine, that is your CNS. Brain and spinal cord is CNS. Anything that comes out from these, we will call it as peripheral nervous system. So from the brain, that is mainly from the brain stem, you get cranial nerves coming out, and from the spinal cord you have spinal nerves coming out, right? Together, cranial nerves and spinal nerve together, we call it as peripheral nervous system. So when I say a peripheral nervous system disorder, we are primarily referring to either cranial nerves or spinal nerves or both being affected. And when the nerves get affected, you may selectively damage only one nerve, like facial nerve damaged or ulnar nerve damaged. Then we will call it as mononeuropathy, when only selectively one nerve is affected. But when non-selectively, diffusely all the nerves get affected, we will call it as polyneuropathy. So GB syndrome is a polyneuropathy. It is not selectively targeting only facial nerve or ulnar nerve or radial nerve or sural. It is generally affecting all nerves. So it is an infection triggered autoimmune polyneuropathy. Polyneuropathy. Okay, that's clear. Now we have to elaborate more on this. So if infection is a trigger, which infection is responsible, right? So common triggers. The most common and well documented trigger, all of you know, that is Campylobacter jejuni. And what does that cause? It causes gastroenteritis. Gastroenteritis. That's the most common cause. But is that the only cause? Can vaccines trigger GB syndrome? Well, there is a rising concern about vaccine triggered GB syndrome. Not very common. It should not be a deterrent for vaccination whenever vaccination is indicated. Of course, the benefits of vaccine outweigh the risk, but there are rare cases where the GB syndrome was triggered by vaccine. So it simply means that any infection can trigger. Most commonly it is GIT infections. Among them, most commonly it is Campylobacter jejuni. So can COVID trigger? Yes, there were cases of COVID triggered GB syndrome as well. So it could be respiratory infections and then vaccines. So these are the common triggers. The most common one is gastroenteritis caused by Campylobacter jejuni. But why does they trigger the damage to the peripheral nervous system? So what they do is, when the infection happens, your immune system produces antibodies targeting these pathogens. Campylobacter jejuni, COVID, or whatever virus, or even the vaccine agent. Body produces antibodies against them. And you might be knowing molecular mimicry. Means our antibody wants to target Campylobacter jejuni. But this Campylobacter jejuni might have proteins or other substances in their bacterial body. And a similar protein may exist, or a similar substance may exist on our neurons. So these antibodies that are produced against Campylobacter jejuni, because of the similarity in structure, they will not only kill the Campylobacter jejuni, but they will also start targeting our own neurons. That is how our own neurons get damaged. So that's why we are going to call it as infection trigger. But infection is not directly responsible for the nerve damage. Infection is only triggering your immune system. Your immune system is causing the inflammation and damage to your peripheral nerves. Okay, and one important rule I want you to remember. Important rule. Generally, polyneuropathies that we talk about, GB syndrome is one, then diabetic neuropathy is a polyneuropathy. GB syndrome is acute, sudden onset polyneuropathy. Diabetic neuropathy is slowly progressing. Then lead neuropathy, lead toxicity, chronic exposure to lead. Then INH induced neuropathy, B12 deficiency induced polyneuropathy. All of them are polyneuropathies. Majority of them are chronic, but GBS is acute. All of them cause length-based involvement of the peripheral nerves. What does that mean? Length-based involvement of the peripheral nerves. So let us say this is brain, this is spinal cord. Okay. Now, if I have to regulate my upper limb, how do I regulate? The neurons will come from the brain, and then in the cervical segment of the spinal cord, they exit to form what we call as cervical plexus, and cervical plexus is the one which is giving the nerve supply to upper limb, right? Most of your upper limb is controlled by the cervical plexus, right? Then similarly, your lower limb is controlled by the lumbar plexus. The nerves originating from the lumbar plexus are controlling the lower limb. Okay. And when these antibodies or any other reason, all the nerves start getting damaged. You know which nerve gets affected first? Longest the nerve, the first to get affected. Why? Simple. All the nerves have blood supply through what you call as vasa nervosa. Means there are blood vessels running over the nerves to give blood supply to the nerves. Nerves cannot survive without the blood supply. Okay. Now longer the nerve, it gets more blood supply. If it is getting more blood supply, it gets exposed more to the antibodies. So then damage also happens more to it. So the first neurons to get affected are the longest ones. Now tell me, in the whole body, which nerves have the longest journey? Is the nerve going from the cervical segment of the spinal cord to the shoulder, or the nerve going from cervical segment of the spinal cord to the hands, or nerve going from the lumbar segments of the spinal cord to the feet? Of course, the journey is longest from lumbar segment of the spinal cord all the way to the feet. So which one will get affected first? The nerves going to the feet. So they will start losing the functions. Then the nerves going to the legs. Then the nerves going to the hands. And then maybe the nerves going to the forearm. So serially, one by one regions start becoming weaker because the nerves to that area, muscles in that area are losing their function. So feet, legs, then maybe hands, and then forearm. So can I call it as ascending paralysis? From distal, the weakness is progressing proximally. So we can call it as ascending paralysis. So these patients present with ascending paralysis because length-based involvement. Longest, the first affected, then the next longest, then the next longest. That's why it's a distal to proximal. And in diabetic neuropathy, you might have also studied that we call it as glove and stocking distribution of sensory loss and weakness, because distal first affected, that is feet, and then maybe hands. That is where we wear the gloves and stockings. That's why it is called as glove and stocking distribution. Okay, so we understood this. Later I will also tell you why I did not accept your autoimmune acute inflammatory demyelinating polyneuropathy as the definition. Okay, so these are the common triggers. So usually the pathogenesis is like this. So it starts with a trigger. The most common trigger is what? Campylobacter jejuni gastroenteritis. So when there is a trigger, the trigger will activate the immune system to produce antibodies against them, right? So immune system will produce IgM and IgG antibodies, and it is the IgG antibodies which are going to be responsible for IgG antibodies are responsible for damage to myelin or axons due to molecular mimicry. And once the axons or myelin are damaged, their function is lost, and you start seeing the manifestations of loss of those functions. These patients will now develop what we call as GB syndrome. So what are the key points to remember from the pathogenesis? Mainly whether it is IgG or IgM. It is IgG. Why is that important? That also means that if I have dysentery today, tomorrow or day after tomorrow, I'm not going to present with GB syndrome. I'll take a week to 3 weeks or more time to present with GB syndrome, because IgG antibodies will start coming later. So soon after the GIT infection, patient is not going to present with GB syndrome. There is always a lag period of 1 to 3 weeks before they start developing the symptoms, because IgG comes then. Okay, clear? Now we will talk about the clinical features. So what are the clinical features? So these patients present with, I have already told you, length-based involvement, right? The longest one to get affected first, then next longest. So they present with what we call as ascending paralysis. Rapidly, it's an acute condition, so rapidly progressing ascending paralysis. Okay, well, but how will I get to know that this ascending paralysis is only because of the peripheral nerve being affected? See, I had dysentery or loose stools. During loose stools, I lost electrolytes massively from my body. So I might develop hypokalemia. Hypokalemia also causes weakness. So how do I say that this patient's weakness is because of GB syndrome and not because of hypokalemia? Or what if the patient has some spinal cord injury also? There also you may have lower limb weakness. So how will I differentiate all of this? Well, examination. So, when we talk about the nervous system, especially when it comes to motor control, from the brain, we always get a signal for the movement of any group of muscle. So from motor area, one neuron brings the signal to the spinal cord, and from the spinal cord, another neuron through the spinal nerves takes the signals to muscle. And the one that is there from brain to spinal cord, that neuron is called as upper motor neuron. And the one that is taking the signal from the spinal cord to the muscle, it is called as lower motor neuron. And this upper motor neuron is there in a tract called as pyramidal tract. And where do I find the lower motor neurons for any muscle? I find them in what we call as peripheral or spinal nerves. So when we talk about GB syndrome is affecting these, right? It is causing the damage to either myelin or axon of these peripheral nerves. So GB syndrome is a lower motor neuron disease. GB syndrome is affecting lower motor neuron. It's not affecting this upper motor neurons. It's not affecting the brain or the spinal cord. It's affecting from the spinal cord to the muscle. When the nerves come, they are getting damaged there. And we know how to differentiate between damage to upper motor neuron and damage to lower motor neuron. So when upper motor neuron is damaged, generally UMN damage is associated with increase in tone, that is hypertonia or spasticity, increase in deep tendon reflexes or hyperreflexia, and you will have a positive Babinski sign. And when lower motor neuron is affected, if that is damaged, you will have opposite of it, decrease in the muscle tone, that is hypotonia or flaccidity, decrease in the reflexes or hyporeflexia, or maybe absent also, areflexia, and you will have a flexor plantar response, not a positive Babinski. So these points you can always write when you know whether the disease is affecting UMN or LMN. Now that I have told you GBS is affecting the elements, so along with this weakness, you will have decreased tone, decreased reflex, and negative Babinski sign. On the other hand, if I had spinal cord damage and because of that my lower limbs were weak, then I will have increased tone, increased reflexes, and a positive Babinski sign. So these points will definitely help us clear. So if you want, you can make a note that GBS is equal to lower motor neuron disease. GBS is a lower motor neuron disease. So you will have rapidly progressing ascending paralysis with what is happening to tone decreased. So that hypotonia is called as flaccidity. And the reflexes, they will also be decreased. LMNC, remember, it's pretty simple. When UMN is damaged, everything goes up. What does that mean? Tone increases, reflexes increase. When LMN is damaged, everything goes down. Tone decreases, reflexes decrease. So flaccidity is nothing but decreased tone, hypotonia, and reflexes will also decrease, or they may even become absent. So we'll label it as areflexia or hyporeflexia. Areflexia or hyporeflexia. Okay. So they present with ascending paralysis, starting in the feet, then legs, hands, then forearms. So it is ascending from distal to proximal. And when you examine the affected regions in those muscles, the tone is decreased and those reflexes may be absent or diminished. Okay. Along with that, you may have mild sensory loss. You may have mild sensory loss. So the story is very simple, right? Someone had a trigger, maybe vaccination or maybe some loose stools, and a week to 3 weeks later, he presented with weakness, which started in the distal body parts and then it is proximally progressing. And when we examined, tone was down, reflexes were down. That's the classical story of GB syndrome. Now that we know how these patients present, let us also talk about the complications, diagnosis and management. So what complications it can lead to? Can GB syndrome kill some person? Can GB syndrome kill a person? Can GB syndrome kill a person? Well, it can. But if my feet are paralyzed, will I die because of that? No. If my leg muscles are paralyzed, will I die because of that? I will become incapacitated, right? I have to be on a wheelchair or I will be bedridden. But directly will I die because of it? No. So if my hand muscles are paralyzed, will I die? As long as someone is feeding me, I will live. But still, GB syndrome patients can die directly because of GB syndrome. How? The proximally ascending weakness eventually may involve diaphragm and respiratory muscles, right? So when they get paralyzed, how will I breathe? Then I may die. So respiratory paralysis or respiratory failure. Second, GB syndrome is associated with abnormal heart rhythms or arrhythmias. So these two can lead to death. Arrhythmias like VT, VF, ventricular tachycardia or VFib, or respiratory failure. The most common cause for death is respiratory failure. Okay, so these are the complications. So GB syndrome has to be diagnosed and managed well. So if I miss, I might lose the patient. So how will I diagnose? So for diagnosis, I want you to write the name of a criteria that we use and the 5 points that I'm going to mention. The criteria that is your teacher's favorite, though there are multiple criteria available. The one criteria that teachers always expect you to write is Brightons criteria. Brightons criteria. So I want you to write 3 points in this criteria, which is very easy to remember. The first one is rapidly progressing ascending paralysis. Ascending paralysis. That is how these patients present. But I want you to write one extra note here. The progression or the progressive phase lasting less than 4 weeks. Why arrhythmias? Okay. So when we say polyneuropathy, we said it is a disease of the peripheral nervous system. And peripheral nervous system not only includes cranial nerves and the spinal nerves. Cranial nerves and spinal nerves are part of somatic peripheral nervous system. But the peripheral nervous system also has an autonomic nervous system, that is sympathetic and parasympathetic. So when they get damaged, they have a control on the heart's rate and the conduction system. So if there is impairment of the autonomic nervous system, the cardiac rhythm will be disturbed. That's how you may end up with arrhythmias. So rapidly progressing ascending paralysis. And then I have made a statement here. Let me elaborate what does that mean. The progressive phase lasting for less than 4 weeks. What does that mean? Let us say I now presented to you with weakness of feet muscles. Then 5-6 days later, the weakness has progressed to leg muscles. 5-6 days later, the weakness has progressed to thigh muscles. So it is ascending. Okay, now 4 weeks completed. 5th week, I notice that new group of muscles are getting affected. Then it is unlikely to be GB syndrome. The progression goes on for maximum 4 weeks. After that, the GB syndrome no longer progresses. No new muscles get affected after 4 weeks. It's because by that time the IgG antibodies start decline, they are not going to cause the damage anymore. So no new muscles will be in. If you have progression beyond 4, 5th week also some new area got affected, 6th week also some new area got affected, it is pointing towards a chronic inflammatory demyelinating polyneuropathy or CIDP. It's a different entity. Then along with that, you will have flaccidity or hypotonia, decreased tone. Then third, your reflexes will be absent, right? Absent or diminished deep tendon reflexes. You can write it as hyporeflexia or areflexia. So these are 3 clinical parameters which we have already discussed. Now 2 laboratory parameters. Either neuroconduction study suggestive of damage to myelin, demyelination, or damage to axon. Axon damage is called as axonal injury. And the next one is CSF analysis. This is what your teachers are again particularly looking for. CSF analysis. Now you may be wondering, sir, we are talking about a peripheral nervous system disease. Peripheral nervous system, is it having anything to do with the CSF? Well, there's a link. You know, if this is brain stem, and then you have this spinal cord, and as I've already told you, upper motor neuron begins in the motor area of the brain, and then it continues its journey all the way to spinal cord. And in the spinal cord, the lower motor neuron starts its journey. So lower motor neurons, cell bodies are there inside the spinal cord, right? Element cell bodies are there in the spinal cord only. And if I'm producing antibodies whose antigens, target antigens, are present on the lower motor neuron, so wherever lower motor neuron extends, the antibodies will go there. And because cell bodies and some part of this element is inside the spinal cord, how will the antibodies reach the spinal cord? They have to reach through CSF. So in the CSF, antibodies start appearing. Okay, so that we can find out on the CSF analysis. How will I find out? Will I go on checking for the antibodies inside the CSF? No. What we will do is we will check the CSF proteins and we will check the CSF cell count. That's a basic CSF analysis. And now tell me, chemically, what are these antibodies? Are antibodies lipids, fats, proteins? What are they chemically? Antibodies are immunoglobulins. Globulins are proteins. So if the antibodies have reached the CSF, CSF protein will increase because antibodies are proteins only. So on the CSF analysis, you will notice that the CSF protein is increased. CSF protein is increased. But then the damage to the neurons is done by antibody mediated injury. So there's not much of cell mediated injury involved. So cells in the CSF are not going to increase. So you will have fairly normal cell count or only minimally elevated cell count. Even if it is elevated, you're not going to get it more than 50. So what is the importance of this? If I have meningitis, let us say bacterial or tubercular or fungal, in that case, protein will be increased, cell count also will be increased. Both are increased. If I have meningoencephalitis, protein will be increased, cell count will be increased. If I have subarachnoid bleed, protein will be increased, cell count will be increased. But here only protein is increased, cell count is not increased. So this phenomena, we will call it as albumino cytological dissociation. Albumino cytological dissociation. Now what do I mean by this? Albumino cytological dissociation. Albumin refers to protein. Cytology means cells. Normally, protein and cells both increase. But here only one is increased, like they are divorced. Earlier they were like married couple. They go together everywhere. Meningitis, both. Right? Meningoencephalitis, both. Subarachnoid bleed, both. But here now they are divorced. Protein is increasing, cell count is not following it. That's what the meaning of albumino cytological divorce or a dissociation. This is an important MCQ point as well for your NEET PG exam. Where do you get albumino cytological dissociation? Classically, can be seen in other conditions, but classically described in GB syndrome. So when you write these 3 features, first 3 are already known to you. That's how we have described the disease. Rapidly progressing ascending paralysis with decreased tone, decreased reflexes. And now lab-wise, neuroconduction study shows either damage to myelin or axon. and CSF analysis shows albumino cytological dissociation. Now that we have learned about its diagnosis, let us talk about the management. How do you manage a case of GB syndrome? So what is my biggest fear if I'm treating a case of GB syndrome? My biggest fear is if the disease progresses and involves the respiratory muscles, patient will have respiratory failure. I have to put him on ventilator to keep him alive. Ventilator brings its own set of complications like ventilator associated pneumonia, barotrauma, volutrauma. Things are messy. And after that, the patient's fate, God only knows. Whether he'll come out of the disease or whether the ventilatory complications will take his life down, I don't know. So I don't want the patient to progress to that stage where I have to put him on ventilator. So how can I prevent the GB syndrome from progressing to involve the respiratory muscles? Who is causing the damage to the muscle dysfunction? The damage to neurons. Who is causing the damage to neurons? We just learned in the pathogenesis. It is the antibodies, right? Antibodies are the ones which are causing the damage to neurons. They are causing the damage to the longest neuron first, then next longest, then next longest. Eventually, respiratory muscles term will come. But what if I remove these antibodies from the body? No more damage, no new neurons get damaged. So then the chances of respiratory muscle getting involved is less, right? So how can I remove the antibodies from the body? Now don't say, sir, I will stop production of antibodies by suppressing the immune system with steroids. That won't work here. Why steroids won't work here? Because already infection has happened, immune system is triggered already, and it has produced the antibodies. Antibodies are already there in your circulation. They are the ones which are causing the damage to the neurons. So even if I suppress new antibody production, the existing antibodies will go on damaging the neurons. It's like, so I have an enemy country and they are charging at us. They are going to attack us now. So it's like, to prevent them from attacking us, I will try to like neuter the whole population of the enemy country so that they won't produce new soldiers. The future soldiers are not our trouble today. The existing soldiers are our trouble, right? The existing ones, how will I eliminate them? Already formed antibodies. See, if I give steroids, B lymphocytes will get suppressed. No new antibody will be formed. Where? But these are the ones which are causing damage. Already formed antibodies. These need to be taken out from the body. So how can we take them out from the body? Number one, you can give IV immunoglobulins to neutralize them. Take them down, neutralize. Or you can remove them from the body through plasmapheresis or plasma exchange. So the mainstay of management for a patient with GB syndrome is IV immunoglobulins or plasma exchange. So what do we do in plasma exchanges? We keep removing the patient's plasma, which is loaded with these IgG antibodies which are causing the damage, and replacing it with another person's plasma which does not have antibodies. So if I keep doing it multiple times, I will quickly bring down the concentration of antibodies in the patient's blood down. Okay, so this is the mainstay of treatment. But then, especially in the Viva OSCE, they will also ask you, okay, I am doing this IVIG or plasma exchange, but still patient may progress to develop respiratory failure, because just because I gave IVIG doesn't mean that all the antibodies will get neutralized, or if I do plasma exchange, all the antibodies will get cleared. Some antibodies may remain and they may continue to cause the damage. So patient may progress to develop respiratory failure. And if he develops respiratory failure, what is my treatment? Intubate, put him on the ventilator, and just hope that no more antibodies are formed. And then the nerves that are damaged start regaining slowly. So eventually respiratory muscles will also start functioning. I will take him off the ventilator. That's my hope. But then I have a question. What is a better idea? Let us say I have got a patient with GB syndrome and I will intubate him once his saturation is very low. He is having severe shortness of breath. I will put him on the ventilator then. That is one choice. Second choice is I will put him on ventilator before he develops severe hypoxia or respiratory distress. What's the best deal? Preemptively putting him on ventilator, like kind of prophylactically, before he develops respiratory failure, or put him on ventilator only if he develops respiratory failure? The answer is experience and studies have shown that whenever a patient is likely to require a ventilator, better to put him on the ventilator when he is stable enough, not when he is critically ill. Because critically ill, the whole scene becomes very messy, right? Slight delay in intubation, his saturation drops down further. You might even end up with a hypoxic ischemic encephalopathy. So intubation is always done in a controlled environment when things are still controllable, not when everything is out of our hands. So we should intubate well in time before he develops severe respiratory failure. But how will I get to know whether he is heading towards respiratory failure so that I can intubate well in time? Once you see hypoxia, that means he has already, respiratory system has gone down quite. So that's like a delayed intubation, I would call. But even before that, I want to identify that this fellow is going down, I need to put him on ventilator, right? So what is the parameter we can use? We can use forced vital capacity monitoring. So if the respiratory muscles start becoming weak, the FVC, the forced vital capacity, starts coming down. So we will regularly monitoring the FVC to identify impending respiratory failure. Impending respiratory failure. And then the rule is, if FVC is less than 15 ml per kg, intubation and ventilatory support is recommended. So this is again something that they might ask you during your Vygotsky or bedside discussion. If you're monitoring FVC, when do you consider intubation? When the forced vital capacity is less than 15 ml per kg. Like a 50 kg person, 15 ml per kg is 750 ml. So if his FVC drops below 750 ml, don't wait for the saturation to drop or ABGs to start showing hypoxia. Intubate him, put him on ventilator. This is the right window for intubation. If you wait a little more time, the saturation drops down, then you have a very difficult critical emergency intubation. Things may go this way or that way during the intubation itself, right? Now, one last thing they might ask you in the discussion is a type of GB syndrome called as Miller-Fisher syndrome. So they might ask you to write a short note on Miller-Fisher syndrome. So I will write a little bit about the types. If it is part of the question, you can discuss that. If it is not part of the question, don't waste your time until and unless asked by them. See, crazy loser. Again, one more important point I forgot to tell you. GB syndrome, the recurrence rate is very, very low, right? You can write it down again. The recurrence rate is very, very low. It is less than 5%. So even if I had GB syndrome because of Campylobacter jejuni infection this time, if I had one more Campylobacter jejuni infection in the near future, I will not likely develop GB syndrome. So immunomodulators, immunosuppressants, they are all used for chronic diseases. See, I'll tell you how autoimmunity works. Either you have humoral mediated or antibody mediated. So let us take the example of antibody mediated autoimmune disorders. So B cells, for whatever reason, either because of genetic abnormalities or something triggering the B cells to produce antibodies against our own tissue, they are producing antibodies, right? And then these antibodies are causing the damage to our own tissues. This is a basic antibody mediated autoimmune disorders story. Now, if I use drugs that suppress the B lymphocytic activity, like the steroids or immunosuppressants or some monoclonal antibodies like rituximab, it's a anti-CD20. CD20 is a marker of B lymphocyte. So all of them are going to suppress the B lymphocyte activity. So antibody production will come down. So the tissue damage will come down. This immunomodulator, steroids, they are all useful for the management of relatively chronic disorders, where you can comfortably suppress this, antibody production will come down and the ongoing damage will come down. But these acute disorders, especially antibody mediated acute disorders, not talking about cell mediated, antibody mediated acute disorders, if I suppress B lymphocyte today, right, then whatever new antibody that is being formed is stopped. But these existing already formed antibodies have a half-life. So till that time, they will keep working. They will keep causing the damage. So in the acute cases, the best thing is to remove these antibodies. That's why we are using plasma exchange or plasmapheresis or neutralizing these antibodies by IV immunoglobulins. They'll fight out and neutralize. And because GB syndrome is not chronic, we don't have to use any of these immunosuppressants or immunomodulators. But if I had, let us say, a chronic condition, like to give you an example, myasthenia gravis. So if I have myasthenia gravis, it is a chronic disease. It is also an autoimmune disorder. Antibodies against acetylcholine receptor. So in myasthenia gravis, when the patient presents, if he's stable, no, nothing much to worry. But let us say an unstable myasthenia gravis patient where respiratory muscles are getting affected because of the antibodies. So in that case, I have to first remove these antibodies. I will follow the same thing there, IV immunoglobulins or plasma exchange. Once these antibodies are removed, the acetylcholine receptors are now free. They start functioning, respiratory muscles will bounce back and the respiratory function is normalized. Patient will come out of the ventilator. But there, it's a chronic disorder. Body will keep producing antibodies again. And then the story can keep repeating again and again. So I have to suppress this antibody production. So in the acute situation, I will remove the antibodies. But after that, because chronically antibody production happens, I have to suppress. So in myasthenia gravis, we do use immunomodulators or immunosuppressants or steroids. But here, because it's not a chronic disorder, there is no role. The recurrence is very low, so we don't have to use. Okay, so now let us learn about the types of GB syndrome and then we will conclude for the day. In the next neuro class, we will study about the myasthenia gravis, amyotrophic lateral sclerosis and stroke. Okay, so types of GB syndrome. The classification is based on nerve conduction study findings. So the first type is called as AIDP. AIDP, as the name stands, it stands for acute inflammatory demyelinating. So as I've already told you, the damage can happen to either myelin or the axon. So it is myelin damage in this case, acute inflammatory demyelinating polyneuropathy. So I have already told you that this, I won't accept it as a definition because it's only one type of GB syndrome where acutely demyelination has happened. This is the most common type, accounting for more than 85% of cases. That's why during general discussions, your teachers also might say GB syndrome is demyelinating disorder. So on a general term, it's fair, but technically GB syndrome is either demyelination or axonal injury. AIDP is a demyelinating type of GB syndrome. The next one is called as AMAN. AMAN stands for acute motor axonal neuropathy. So there, as the name says, it's all there in the names. This is demyelinating type of neuropathy. This is axonal injury type of neuropathy, right? Then we have one more called as AMSAN. AMSAN stands for acute motor, and this is where the difference is. So the AMAN has spared the sensory neurons. See, when we studied about the symptoms of GB syndrome, we learned that there is usually mild sensory loss. But AMAN does not touch the sensory neurons. It only causes the axonal injury to the motor neurons. So symptoms will be only rapidly progressing ascending paralysis, flaccidity and hyporeflexia, but no sensory loss in case of AMAN. But AMSAN will include sensory as well. So it is acute motor and sensory. Injury is mainly to axon. So it is acute motor and sensory axonal neuropathy. And then we have a relatively rare variant called as Miller-Fisher syndrome. Miller-Fisher syndrome or MFS. This is relatively rare. It is a rare variant and it is way different from your other GB syndrome cases. And I would be happy to get a Miller-Fisher syndrome patient than an AMAN or AMSAN patient. Why? So first of all, among all these cases, the AIDP and Miller-Fisher carry good prognosis. Miller-Fisher also carries good prognosis, but Aman and Amsan carry poor prognosis. Can anybody tell me what could be the reason why they have poor prognosis? This also carries poor prognosis. The reason is it is more easy for the body to remyelinate than regenerate a injured axon. So axonal injury is difficult to recover than demyelination. So if there is demyelination, we can easily recover. That's why this carries good prognosis. These patients' chances of going back home without dying in the hospital is high. These are the patients who are more likely to land up on ventilator, Aman and AMS, because the condition progresses and it takes quite a bit of time for the axonal injury to settle. Now, why Miller-Fisher syndrome is peculiar and why this carries good prognosis is because unlike the AIDP, Aman and AMSAN, which are mainly motor, mild sensory involvement, or Aman no sensory involvement at all, Miller-Fisher syndrome predominantly affects sensory more than motor system. And I'm so happy about it. Why? Because if motor system gets affected, eventually my diaphragm and respiratory muscles will become paralyzed. I will land up on ventilator and may die. But if sensory is affected, I will lose sensation, and nobody dies because of the loss of sensations, right? I will lose sensation, but will I die because of loss of sensation? No. I can die because of motor strength being lost in respiratory muscles. That is unlikely to happen here. That's why it carries good prognosis. And because it is involving sensory more than motor, it presents with mainly sensory system related symptoms. So what are those? The first one is your cranial nerves going to the eyeballs may have weakness. So you may have ophthalmoplegia, and more important than that, this is what your teachers want to hear from you, that is development of ataxia. And this ataxia is a manifestation of sensory system involvement. Now you may ask me why or how. Well, our brain gets to know whether our body is perfectly upright, tilted, leaning forward, leaning back from various systems. One of them is vision, right? So if I can see, I know whether my body is tilted, angled, straight or not. This one. Second, you have a vestibular system. You have studied in detail in ENT, which is giving a constant feedback to the brain whether your body is tilted or not, right? The third one, which is helping you to know whether you are in a upright, acceptable stature or not, is your sensations. There's a sensory signal called as proprioception, right? What is this proprioception? Proprioception refers to joint position sense. What is joint position sense? If you ask someone to close the eyes, flex or extend one of their joint, and then ask them whether you can tell me whether this joint is in flexed position or extended, they should be able to tell. Like if you hold somebody's wrist and flex it or extend it, or elbow, flex it, extend it, or do it with any small joint, they will be able to tell without looking at it, right? So the brain is constantly getting the information of the position of joints. That sensation is called as proprioception, and that is important for the balance. Why? Because even if I close my eyes, now I'm not seeing, but at what all angles my joints are flexed or extended, that information my brain is getting, and it is able to process and get to know whether my body is straight or leaning in any abnormal direction, and whether I need to do some counter correction. But if I lose the sensation, proprioception is not there. I've closed my eyes. So visual feedback I'm not getting. And from the sensory, I'm not getting to know whether my joints are in the right acceptable condition or not. And with that, I start losing the sense of balance. I get ataxia. This form of ataxia is called as sensory ataxia, right? So because here Miller-Fisher syndrome, the damage is more to the sensory neurons, we are getting this loss of proprioception presenting as sensory ataxia. So I might have ataxia, but that is unlikely to kill me. So that's why the prognosis is good, right? So we are going to call this condition as Miller-Fisher syndrome, right? So that completes our discussion on the GB syndrome as well. So right, let me quickly summarize what we have learned about GBS. GBS is a lower motor neuron disease. It's an infection triggered autoimmune inflammatory polyneuropathy. Most common trigger is Campylobacter jejuni, infection of the GIT, but other infections can also cause. So when infection happens, immune system produces antibodies against those infecting microorganisms, but because of molecular mimicry, either they will cause damage to axons or myelin. If myelin gets damaged, we call it as AIDP. If axons get damaged, we will call it as AMAN or AMSAN. If it is motor and sensory both affected, we call it as AMAN, AMSAN. And if it is only motor axonal injury, we will call it as AMAN. They present with rapidly progressing ascending paralysis with flaccidity, hyporeflexia, and except AMAN, other variants have some degree of sensory loss. Miller-Fisher has predominantly sensory, most others are predominantly motor. And overall, AIDP being most common, motor is the most common dysfunction. So you may eventually develop respiratory failure, and that is the most common cause for death as well. So for diagnosis, we are following Brightons criteria, 3 clinical and 2 lab parameters. Clinical is the history, rapidly progressing ascending paralysis, loss of reflexes, loss of muscle tone. Lab is nerve conduction study, either proving there is demyelination or axonal injury. In AIDP, you will get demyelination. In AMAN, AMSAN, you get axonal injury. In the Miller-Fisher, it is predominantly demyelination. Some degree of axonal injury can be there. It's mixed. CSF is the fifth criteria or the lab parameter. Increase in protein, but not much increase in cell count. We call it as albumino cytological dissociation. And because these patients can progress to respiratory failure, we need to monitor. The mode of monitoring is forced vital capacity and not your saturation. FVC monitoring is recommended. And the patients, to prevent developing the respiratory failure, we have to consider IVIG or plasma exchange. It's not a chronic disease. It's not a recurring disease. Recurrence rate is less than 5%. If they're specifically asking you to write a note on the types, AIDP, AMAN, AMSAN. AIDP is demyelinating type. AMAN, AMSAN, the axonal injury type. Miller-Fisher is predominantly demyelinating type. Most common is AIDP. AMAN and AMSAN are next most common. Miller-Fisher is a rare variant. AIDP, because demyelination carries good prognosis. Miller-Fisher predominantly sensory, so it also carries good prognosis. AMAN and AMSAN axonal injury, so they carry poor prognosis, right? So that's it from me today on neuro part 1. So we have yet to discuss other major questions from neuro that will include the myasthenia gravis, stroke. Stroke is the most likely major question from neuro for most of the universities. Some universities have started asking multiple sclerosis as the most question, and some universities they have started asking the motor neuron disease classification and amyotrophic lateral sclerosis combined as a main question. So these 4 questions we will address in the next neuro session, right? So study well, and other important questions are definitely covered in the Farre note, so you can definitely refer to the Meded app in the Farre section. If you want any particular question to be addressed, ping me on the Instagram. I'll try to cover that in the next session, right? So see you soon, guys. Study well. All the best. Bye-bye.